Thank you guys for coming out, listening to us talk about some long-term care at home, and just how to de-risk your pharmacy a little bit, make it a little bit better. Out of curiosity, who here has a Manic Monday pretty much every Monday? It's a little bit heavier than every other day of the week, maybe about 20-25% higher volume. Yeah. So that's pretty common across retail community pharmacy. It's because by definition we're a reactive model. We're waiting for patients to call, click, or walk into the pharmacy. And what we're going to be talking about today is ways to de-risk that, to spread that workflow across the rest of the week, and really just change your whole pharmacy output and really go down that pathway. I'm Paul Shelton. I'm the CEO of the Long-Term Care Home Pharmacy Network, president of Pharmacomplete, and also operate a couple pharmacies. I'm going to let the rest of the team introduce themselves real quickly. Kind of two-second intro. Ready to go.
Sure. I'm Scott Kowalski. I'm the Chief Growth Officer at Medsense Health. We're a medication adherence and remote patient monitoring company. All our services are covered by Medicare, so I'll get into a little bit more about how we deliver those services.
Yes, I'm Jeff Hetrick. Own a pharmacy up in Victor, New York. That is a non-retail pharmacy. So we have 500 long-term care at home patients. And by the way, they did make a typo on that. I am not a pharmacist.
My name is Tanner Cochran. I'm a sales manager for GeriMed in the complement market. We hold the contract, so we get the increased reimbursement for you and those upfront discounts.
Hey, my name is Brian Glaves. I'm the VP of Sales for RxSafe. The picture that was up there earlier is a rep that used to work for me, and we would prank each other fairly often. So he wins if he's here somewhere. Good stuff on that.
That's great.
I'm Justin Ceravolo. I'm a pharmacist and owner of Cypress Wellness Pharmacy down in South Florida, so not too far from here. And we're retail, and we've been getting into the long-term care, especially after having a meeting with Paul and their team, and just showing the potential that we were really just losing out on. So that's kind of what we're going to get into.
Absolutely. So thank you guys for joining us. Obviously, we're talking about not another Manic Monday. We're also talking about how do you provide care outside of the four walls of your pharmacy. I think there's so much push to have patients come to us. There's so much push to have patients really change who they are and where they are. And in reality, I think a lot of us are thinking about how can we actually go to our patients to serve them better. I think, Jeff, you've got a great story about like kind of that concept of LTC-at-Home and how you balance your workflow. And it's really what you're doing on a weekly basis to kind of keep patients in home happy and healthy as long as possible. I'm sharing just a couple bits about like how you got to that 500 long-term care home patients. Your origin story, if you will.
Yeah, we did have a retail pharmacy that I sold to Rite Aid. We see how well that worked out for them. Huh? So we actually split it. I sold the retail patients. I kept the LTC patients. We do have an advocate that maintains relationships with all of the nursing community, the hospitals, all of the care people, the people that go in and take care of people in home. So because of those relationships, we get calls, anywhere from 5 to 10 a week. Can we take on this patient and help them? So that's how we grew to 500. Our biggest challenge, when I spoke the other day, was we lose a lot of people. Right? Either pass away, they move into other types of care, assisted living, skilled living, and or you get the other oddities in life. They don't think they need to pay their copays, things like that. So we lose them on purpose sometimes. But short of that, that's how we grew, and that's what we do.
Okay. Justin, same question. How did you, obviously you started with retail pharmacy doing the standard kind of traditional business, but how did you get to where you are today with LTC-at-Home and growing that model?
Yeah, a little quick background. Fresh out of college, I met this company. It was Cypress Pharmacy, and then started working for them for a decade. We ended up getting a packing machine, the rapid pack machine, and we were doing packs for all these patients. And I didn't know because I wasn't an owner or anything at the time, but we weren't doing any long-term care and home building, nothing of that nature. So we were doing all these services that had a delivery service, packaging, and we were just getting the regular reimbursements, and they weren't even charging extra to like run a pack machine. So at another conference, I took over a couple years ago, and so at a conference I ran into GeriMed and Combo Med, and we just did an evaluation of everything that we were already doing, and they showed us what we were missing out on. So we didn't have to change anything that we were doing at all. We were already doing, and just that's how long-term care for us just made perfect sense, because it showed the reimbursement differences with some of these insurance plans, and some of them you don't even have to sign a contract for. Sign up with GeriMed and that's included for you. But the amount of patients that we had that were already eligible that we were doing these services for, the difference in the margins for these claims made a huge difference. It was just a no-brainer for us because we were already doing the service.
Yeah, that's a great point, Joe. So I think a lot of pharmacies that we don't do, we go out and do ops assessments, we do long-term care home population assessments. It's amazing. We're averaging about $5,000 per pharmacy per month when we do that assessment. So you're looking at kind of what's the reality. Small pharmacy in a little central North Carolina town that is where my youngest child goes for medication. The owner was hilarious. She's like, we're going to do all these things. I was like, okay, but focus on one. Pick one thing that you're already doing. So you're already packaging for 120 patients. They're already doing the compliance packaging, the delivery, the monthly med reconciliation calls. She's like, it's too much work. So we went through basically the credentialing process, helped her do that. We moved 32 patients over, just 32 patients. It was a $3,600 impact. Exactly what you're talking about. They were already doing all the work. Like you're spending all this money to deliver and provide that monthly med rec. Convert those patients over. And it's not like we cherry pick. We just literally said first 36 patients in your packaging program that meet the criteria. Let's send it. And that's consistent, right? Like, so the same thing Jeff said, it's like you got to find those resources, those reference points, bring patients into your pharmacy that, maybe fall through the cracks in other pharmacies. Also reach out to those referral partners, provide them feedback. It's amazing how much just a little bit of communication makes a tremendous difference. Doing a physician outreach program, we're actually engaging a physician and saying, hey, Paul's at this pharmacy, he's getting these services, this is our program, here's his mark, and these are the 5-star questions that I asked him. Does that provide value? And we've seen this time and again, and especially in rural communities, doctors are so used to not having any support from community pharmacy, they don't think to ask. They don't think to say, is there something else that can be done here? And we have a pharmacy in southeastern North Carolina ended up receiving 200 referral patients in less than 3 months. Just because they asked the question. It was literally, they fill the form out, send it over to the doctor. The doctor's like, what is this? Push it over. So, Tanner, if you don't mind, can you walk us through kind of what are the challenges? Like, obviously, if you're doing this work already, what's the time frame? What's the challenges to actually get set up and get on a contract?
Yeah, so typically the general rule of thumb is going to be 60 to 90 days. It can go faster. It can go slower. Ultimately, it's going to be on the pharmacy to actually get the paperwork done. We also rely on the manufacturers, the wholesalers, and the insurance companies. I would say the insurance plans, depending on the plan, once you submit that paperwork within 30 days, you can be set up. So it's ultimately just about getting that submitted, staying on top of things. I know a big issue we see is pharmacies are just flooded with emails. So a lot of stuff gets missed. So I always recommend checking in with your GeriMed rep, saying, hey, where are we in the process? I haven't heard anything in a couple weeks. Let me know, and we'd be more than happy to help.
Jeff, yeah, don't forget though, you do have to get separate long-term care numbers. You have to get duplicate and CPDP and MPI numbers. And then they take over.
Let's talk about that real quick. So that process basically is you got your retail community pharmacy, maybe your community pharmacy also compounds. You got your one state license, you got your DEA, you got your NCPDP, your MPI and NCPDP. And I think what you're talking about, Jeff, is that dual taxonomy concept. You can grab a second NPI that's primary taxonomy is LTC. Right. Then you get a second NCPDP, and now you can actually get that set up, link it to GeriMed, link it to your PSAO, your GPO, and then that gives you access to these contracts. Optum is an immediate contract pickup. Once you're rostered with GeriMed, you send in the application to ESI, and I know if your community pharmacy And that's all you've done. ESI might as well be like any other 4-letter word, even though it's only 3 letters, because they don't necessarily pay well on the retail contract side. In long-term care world, though, they are a fantastic partner, a fantastic payer. They actually reimburse very appropriately for work that's being done. And so it's a little bit of a brain break for a lot of community pharmacists. You're like, no, not working. Trust me. Get the ESI contract, you're gonna be happy with it. And then you convert those patients over. Unfortunately, currently CVS nor Humana recognize LTC at home, but they do recognize institutional LTC. So if you've got patients in a group home, if you've got patients in home health care like an adult daycare center, or Shoppe, if you have an IDD patient who lives at home that goes into Shoppe and receives care for a few hours a day, those patients all qualify as institutionalized care patients, essentially an assisted living patient. And so you can bill CVS and Humana for those patients, but not the LTC at home.
And I was going to say, kind of to your point, Paul, a big one that people forget is that adult daycare. A lot of times you wouldn't think of that as being an institutional patient, but as long as they're providing transportation and administering medications, often those patients will qualify under those care mark contracts.
And it's interesting because, so adult daycare is one thing, but if you think about, there are these home and community-based waiver programs that are specifically for IDD patients. Those are patients with intellectually developmentally delayed services needs. And they go to something called Shoppe. And Shoppe is an awesome process where an IDD patient can be empowered to become more independent by coming and performing work in a controlled environment. But care is also provided in that environment. In many cases, transportation is provided. They administer medications at lunchtime, sometimes multiple times throughout the course of the day. And so that Shoppe process actually qualifies as an adult daycare center through those CVS contracts as well. And so it allows you to go ahead and bill those patients on an 04 patient residence code for increased reimbursement. So as we're doing this, as we're taking care of patients, as we're engaging patients, I think what's really interesting here is we're trying to keep patients where they want to be, happy, healthy, and at home as long as possible. And so one of the things that we can do with that is actually taking care beyond the pharmacy wall one step further. And so there's some relatively new concepts in the market called remote therapy monitoring, remote patient monitoring. And Scott has some really interesting insights about some things they've done recently that it's not 100% dependent upon the pharmacy. It's not incumbent upon the pharmacy to do all the work. So Scott, share a little bit about what you guys are doing that's innovative.
Yeah, Paul, we basically pick up when your patient leaves the pharmacy, we pick up at that point. So we follow them into their homes, into independent living, things like that. We use sensing technology to determine when they've taken their medications, or more often than not taking their medications. We developed a little sensor that picks up unique motion profiles. So it'll pick up the turning of a cap on a vial, the flipping of a lid on a 7-day pill organizer. In your world, packaging of some sort is a requirement to be long-term care at home. So we developed a system right now where your script packaging or your box slides into a little station of ours that also has a sensor in it. So I have parents in their 80s and they use strip packaging, and the nice thing is that all 7 of their meds are in one little packet. The bad thing is when they forget all 7. So our sensing technology picks up when Uncle Larry, or in our case Father Tom, picks that packet out of that little box. If he was supposed to take that at 9 o'clock, it's now 9:15. I can send him a little ping on his phone and say, hey, Dad, it's 9:15. You were supposed to take your heart medication at 9. And he's a little forgetful. He wants to be compliant. He's not trying to trick the system. He just forgot. Oh, gosh, right. Runs up to his bathroom, takes his pill. We send him another text saying, hey, Tom, your dose has been recorded. Congratulations. Keep up the good work. On the clinical side, we're gathering all that information. So it's another data point for pharmacists, primary care docs, live-in nurses, family members, to see how mom or dad are doing. And it's amazing. When I came on 5 years ago with MedSense, and it's amazing if you just look at a 30-day run chart and see, it just tells you so much on what somebody's doing. Right now, a lot of your information is from refills. That's pretty much it. Somebody refills 9 times a year, 8 times a year. We can tell you what folks are doing on a day-to-day basis. We are monitoring 24/7. The other thing that we learned very early, well, I shouldn't say that, not very early. We realized early on, I'm a recovering health insurance executive. Our founder is a young physician. So neither of us were pharmacists. And when we started realizing that independent pharmacy was a great space for us, we hired a woman that had a lot of experience in this space. And she was like, guys,
cool technology, great idea, et cetera, but it's all about the workflow. And we started talking about the easy button. And we were like, what, they're like, you got to make this simple. Yeah, there's got to be a revenue opportunity here for pharmacists, and there is. We collect the reimbursement, we do all the billing, and then we share that revenue back with you guys, so there's no upfront cost. So our model's a little different. But we didn't start there. We had to learn that over time. So we kept talking about the easy button. And I'm like, well, are we going to have to do the billing? Yeah, it's Part B, right? Pharmacists don't like to do Part B billing.
Or in many cases can't do part billing because of the
Or
same
had a bad
requirements.
experience in the past,
Not a
whatever.
provider, they don't cancel. Yeah.
That's my background. I spent 15 years on the insurance side, handling that kind of stuff on the processing side. So I was familiar with that. Okay, great, no problem. We'll take that off their plate. And we just kept going. And we realized as I got more comfortable in the pharmacy space, you've got to make it simple. And for us, a Monday is no different than a Friday. If your pharmacy is open on a Saturday, we'll call patients on a Saturday. So we do all the outreach for you because your staff is too busy. So I'm like, well, pharmacy technicians, they can make those calls. They can introduce our service to their patients. And Jen is like, no, they can't. They're a little busy. Have you ever seen what's going on behind a pharmacy counter? I'm like, yeah, they look like they're running around with their heads cut off back there. I'm like, yeah, when are they going to step aside and make outbound calls to patients? Like never. So we built a call center. Well, this has to be approved by a physician, right? Unfortunately, we have to have a physician somewhere involved here. Well, we're talking to pharmacists. Well, just enter a collaborative practice agreement with your physician down the street. A lot easier said than done.
Well, it's not even, and it's not even that it's easier said than done. In many states, it's not allowed. There's barriers regulatorily, and frankly, it just becomes very challenging for the pharmacies themselves to be able to handle this extra work. I mean, again, who here has 5 technicians who are sitting around doing nothing? I think pretty much every pharmacy in this room, listening to our last conversation, we've got our foot on the gas as hard as we can go just to get the things done that we need to get done in an average day. And so, I'd be really interested, Justin, if you guys heard of it, how has this impacted you guys as pharmacies, or how is this kind of working alongside your pharmacy?
I'm sure a lot of people are in the same boat that most of us are in as independent owners, is that no one can really run things the way you want them to be run, as well as you like them to be done, the way you want it to be done. And so, I've been like a one-man show for a lot of it, and I've tried to hire people, and they just don't pick up, and it doesn't work out. And these programs are not something that are a lot of work, and there's a team behind them. So if you have that patient repertoire, and they come in with their questions, and I reach out to Medsense all the time and say, hey, my patient has this problem, and then Medsense team takes care of it. Right. I have a long-term care problem. There's a long-term care team with GeriMed and everyone else that takes care of it. But in the workflow, the Medsense program is super easy, and it's popular for us too because we have a lot of patients that are in a nursing home or facility, and their kids live in a whole other state. And so the kids are actually getting the notifications for their parents so that they're knowing their parents are taking their meds or if there is a problem, which has been really nice. But the workflow is really easy because most of these patients are already in our med synchronization program. And now you just log into the Medsense portal and it breaks it down much easier for you to where you can see a chart of they're taking their meds on time. So we can show in our system that we're filling them on time, but we don't know what's happening at home. Right. And so this has been a very nice to do that. And now we get credit for it too. So
Right.
The conversations that we're having with them on a monthly basis anyway, it doesn't even have to be a long conversation. You're just simply reviewing their meds.
Well, and that's part of your normal workflow already, right? So as part of long-term care at home engagement, you have to contact the patient at least one time a month and have a medication reconciliation conversation. It can be something as simple as if there have been no changes, if you have any concerns or questions about your packaging, is there anything you need to do, anything you need us to do? Great, that's how long that conversation needs to happen, quite literally. We just need to have that conversation once a month to make sure there's been no changes for the patient. That's already happening as part of your workflow. You just have to enter it into the Medsense platform.
And I'm horrible with it. There's a lot of times where I forget to even go online to Medsense and document it. Yep. So I do it all the time, but I have not myself. I've been my biggest downfall with my growth is I'm not even getting the credit that I'm already doing.
Exactly. Out of curiosity, folks in the room, who here is actually doing any LTC at home or LTC currently? All right, that's awesome. That's great. All right, so
who here is not doing LTC at home, but is packaging, providing monthly medication reconciliation or delivering to a patient currently? All right, awesome. So what I want you guys to hear from this, specifically from what Justin just said, is you're probably doing 95+% of the work already that you need to do to qualify for a patient at home. It's not just packaging, it's not just delivery, it's care coordination, it's engagement with the patient, it's getting that monthly medication reconciliation performed. But when you do that, I mean, out of curiosity, Justin, and Jeff, if you don't mind answering this one up, what's the difference for you between a retail reimbursement patient and a long-term care reimbursement patient? And doing top line, like just kind of top line it, kind of massive difference.
Yeah, a retail reimbursement, because we do still get a few patients that fall under retail because of retirement, health insurance and stuff like that. You were like if you owned a company and your company's still ongoing, you're probably still on that insurance. That's commercial insurance. That we don't turn them away, but we only average about $3 a script profit, which is what I would think most of you are seeing in retail, and that is previous to drug rebates, just flat out invoice cost, $3 a script profit. In long-term care, we're ranging between $12 and $15 per script. A little bit less on certain bins. It jumps around a little bit by bin. Your Cigna bin for ESI is going to be bad. Your Aetna bin for Caremark, even though we get paid retail Caremark, that's worse. Okay.
Humana's a start sharp.
Yeah, I don't take Humana. I got out of it. That's all I do is LTC at home, and we happen to deliver 30 square miles. I couldn't deal with the $1 or $2 a script Humana reimbursement, praying that maybe next year I'll get the rebate. Yeah. So I got out of Humana.
We'll circle back to that delivery radius in just a
Yes.
second. But Justin, in your pharmacy, what are you seeing is that delta? Is it that same $9 to $10 per prescription on average difference between retail?
Generally, but I mean, I have some scripts where I was making like $20 on, and it's gone up to 60 plus.
Right, exactly. You do have the one-offs that are just insane. So when you think about the average patient in this population, it's all about 9 medications. You know, when we do broad, like 300 pharmacies, we look across 300 pharmacies who are the LTC patient, LTC home patients. We're seeing a rough 9.2 prescription per patient increase, or average. That sounds about right? And so when you think about, all right, if I'm making $8 per prescription on 9 prescriptions, that's $72 more per month. And then when you layer in, Scott, what's the average kind of per patient medicines compensation for the pharmacy roughly?
We get $25 per member per month.
Yeah, $25 per member per month. Yeah, these are overlapping fields of fire. So when you think about this, you're talking about something you're already doing. You're having to have those medication reconciliation conversations for your LTC home reimbursement. You can also tag that same thing into this. So now, if every patient you're looking at in your pharmacy, we're seeing about a 7%, 8% conversion rate in most pharmacies over total patient population. So if I look at a pharmacy, maybe doing 300 prescriptions a day, 2,400 of the patients in that pharmacy, 7% of them convert, it's 140 patients. Now, again, I'm not a math magician over here, but if I can add $100 per patient, that's $14,000 more per year, or excuse me, per month, that we're capturing on those patients. So now we're talking over $160,000 a year for work that many of you are already doing 80% of, right? And so I think our intent today was really to talk about how we change this and how we make it easier, but it's also, I think, just to reinforce, this is a very addressable space. This is something that I think all 6 of us would say, this is a challenge, it takes time, but it's addressable. Every pharmacy in here can do this. And there's a need in every community. I think we've done 317 assessments at this point for long-term care at home. We found 15 pharmacies that didn't make sense for it. Of those, they were either very, very, very high Medicaid, because Medicaid doesn't pay extra for this as of today. We're working on that. Or they were already rural rate contracts. If you're on rural rate contracts, okay, I get an extra 2 pennies for this patient, I'm not going to go through the extra effort until someone builds a pharmacy next to it. So yeah, it's the concept here is you can capture a ton more revenue per patient by helping increase the outcomes.
I think that's really what we're all shooting for here. And I know, Tanner, you guys have had some real interesting conversations with payers around what's the intent, right? What are we trying to achieve here?
Yeah, and that's what I was kind of going to say, especially with Scott and the MedSense program. When we go to negotiate these contracts, ultimately the PBMs are looking for better patient outcomes. If we're not saving them money, then they're not going to give better reimbursement. Right. So stuff like Scott's technology is a great way to ensure that those patients are actually, taking their meds correctly. And actually, that's one of the ways that the LTC-at-Home got started. Some of you may have remembered back in the 2010s, there was beds to meds, and where people would reside in a hospital or skilled nursing, they would be sent home with a 90-day supply. All of a sudden, rehospitalizations, they're not taking meds correctly. The insurance cost skyrockets. So that's really where that LTC-at-Home came in place to stop those rehospitalizations and really give those patients the extra care they need once they get home.
Yeah, absolutely. So, go ahead, Jeff.
Yeah, one of the things that I think sometimes is the folks that are doing it but haven't jumped into it is sometimes people don't want all the patient growth because you're in a point where if you're doing 50 of them or 70 of them out of your 80,000 retail scripts, it's just a pain in the ass. I mean, in some respects, okay? But like, besides my pharmacy, I have another pharmacy I still consult with because we sold it to the pharmacist 3 years ago down in Pennsylvania. Now, she's a heavy retail pharmacy, picked up 20,000 patients last year. 20,000 scripts, I'm sorry. Went from 90 to 110. But she followed with what we did. We finally did put an RxSafe robot in because I was at that point, clearly. But she did that also. So she has no problem keeping up with her 350 PAC patients. At the same time, she's doing another 60,000 retail scripts and DME. So like in her particular case, no extra labor from 1 year to the next. But she did also put a script pro in. That was a big, because of Rite Aid closing, she picked up a lot more retail. So she put both robots in, and at the end of the day, no extra labor.
Brian, that's a great question for you. So as you're looking, you're talking to pharmacies and they're growing, when you think about like some of the pharmacies we've talked about, they've added in 100, 200, 300 patients over the course of a 12-month period. Normally that means if I'm adding 3,000 prescriptions a month, I'm going and finding at least one technician, probably a part-time pharmacist. But interestingly, when we talk to a lot of your customers, they're not happy to do that, right? Like, so what are you seeing in the market? Like, where's that kind of inflection point where it makes sense for someone to start thinking about when do I automate? How do I automate?
Yeah, great question. I worked with Jeff 15 years ago trying to get to sell him a script pro, and it took a lot of time. Jeff's not an easy customer. I think on the RxSafe side, we worked quite a while, probably another 10 years on that. Yeah. And he made the decision at Atrium last year. So Jeff's an operator, as a business person that has the processes in place. He's got everything that's there. So when he says, I don't need a robot till I hit 500 patients, he's exceptional in that space. A lot of our customers are more in that, probably 50 to 100. Jeff says it's a pain in the ass at that point. That's right. That's where we get to where it's enough that it's uncomfortable,
Right.
but it's not enough to hire someone else yet. And you get to that spot where you're like, hey, I need to bring some more labor in. I'm talking about the Pennsylvania account, like I need more labor to handle that. That's where it makes sense to look at automation. We're a tool that's going to come in there and provide an efficiency and an accuracy that's there.
And what's important on that too is, like you said, your tools to provide efficiency and accuracy, right? So it's hilarious the number of times I see people spend, however much you're buying a robot for, it doesn't matter the type of robot, and then they make no changes to the workflow. Oh my gosh, the whole intent here is you've got to modify what you're doing to fit the new reality. If you're doing disc bill as an example, right? So disc bill, Cube, SureMed, any of those multi-dose compliance packaging that you're filling by hand, a really, really talented technician can fill one patient every 24 to 26 minutes.
Yep.
And that's for a 4-week supply. And a really good pharmacist can check those 4 cards in about 6 to 7 minutes. Now, if they're doing it properly and the patient's on 11 or more medications, it's probably a 9-minute inspection cycle. So if you can take that 9-minute inspection cycle and crank it down to a 2-minute inspection cycle, and it doesn't have to be done directly in front of those cards, That's an incredible change in labor model. I mean, all of a sudden, you're not having to hire that next pharmacist. You're not having to bring in that next technician because, again, if you're following the workflow, it's very easy for one technician to easily fill. I mean, we were talking earlier before I think just like you got one technician that does all 500 of my patients in 32 hours a week. I'm sorry, what? That's wild. I mean,
That's 125 to 150 patients a week.
Right.
Because it breaks down every 28 days. But the other thing is my pharmacist told me once they got used to visual checking, like, we're leaving if we ever go back. You don't have, so those of you that are still running retail, it's a big thing. Being able to cut down that load, a pharmacist check, big thing. Almost bigger than the technician part.
We go through a lot of the numbers as well, like, hey, you can say this much, you can do this much. We took a site visit to Jeff's store, I don't know, a month or two ago, and talking to Phoebe, who's his technician, she's putting together 37 to 39 patients. She's a machine. But his pharmacist, Caitlin, like, she has this stress that was relieved. She showed me all the tools that she uses to look at cards before, and now she looks at the screen, and she's just like, I go home at night, and I'm relaxed. I can have a glass of wine. Like, I'm not worried that, did I do this or did I do this wrong?
Yeah, Justin, what were you going to say?
Yeah, I mean, this comes down to not, like I said earlier, is starting kind of slow and building yourself up so that you get into that rhythm of things. I mean, I have a technician that's really good with the pack machine now, but she literally has a binder with everyone in there now, and that's what works for her. She has everyone on a calendar for the whole year planned out, so she knows exactly when she's starting everyone and when to follow up with the doctors and when we need prescriptions, this and that, but not overwhelming ourselves with saying we have 1,000 patients that are eligible for this. Let's just go home and go for 1,000.
Right.
I mean, before I got into it, I met a pharmacy, and he said he had one patient that made it worthwhile. And then they just slowly started adding on more. But just one patient alone, financially, it made sense for them to even do it.
Yeah. And when we run the numbers, especially when you're talking about 32 patients, $3,600, right? So the total cost, if you're looking at like program that Tanner runs, the complement program, is $200 a month, right? Okay, for $200 a month, you get access to ESI and Optum contracts, which I will argue that about 3 patients covers that cost for the entirety of your year. And so that's an easy cost. And you look at, okay, what's the cost of a machine? Let's say just for round numbers, $4,000. Okay, I add another, call it 30 patients, and now that's done. And now I have the ability to grow, not have to change my labor model, and just rock and roll. And it's been wild seeing pharmacies that are like, again, we see pharmacies automate as early as like 55, 60 patients a month. And a lot of people are like, are you absolutely out of your mind? What are you doing? I'm like, no, I trained them now where it's nice and easy. And it's all covered. It's all this is covered by the increased reimbursement. Tag in some extra medicines reimbursement in there. It makes a heck of a lot more sense. And now I can go and actually engage my local physicians. You guys go out and recruit patients all the time. You have a great funnel. I mean, you're talking about 5 to 10 patient referrals a week. Justin, what's your referral source right now? What's that funnel look like for you guys?
I usually go out and pay my visits to doctors in the area. And then also, since we do the packaging, we have our boxes with packs floating around everywhere. So we have patients that come in all the time, and then we have it displayed in the pharmacy too. And so we have some patients that just want their vitamins done that way.
Right.
But the spreading the knowledge that we can do that, doctors just weren't aware that I have doctors in our area that still don't even know where we are. So I've actually invited doctors into the pharmacy to just stop in and see what we do, and that has just spread the word for us. So it really just letting everyone know what you do is a big part of everything, and then everything just filters into place at that point. The compliance, reimbursements, everything just falls into place.
That's right.
As a quick show of hands, out of curiosity, how many people in the room have invited either doctors or local nurses to come into your pharmacy and see what you do that makes you different? Okay, so if you have not done that, one of the things I'll take is a massive action item for everybody in the room. If you have not reached out to your local U.S. House of Representatives representative, and at least in both of your senators in your state, and asked them to come and visit you in your pharmacy, do that.
There's a massive push on Capitol Hill right now to fundamentally change how pharmacies get reimbursed. And one of the big issues that we're running into, I talk to reps literally on a weekly basis. They're dying for information. They want to be informed. They want to understand why this is important. They want to know what you're doing that's different than the Rite Aid, than the CVS, than the Walgreens, because they have this concept, they know something's different, they don't know quite what. If you haven't invited your local doctors or nurses to come in and see what makes your pharmacy different, you're missing a tremendous opportunity. One of the pharmacies I'm managing right now, we service closed-door long-term care patients. And we had one of our regional managers, so she manages 4 separate facilities, and she brought in both of her DONs from one of our facilities that they're struggling a little bit with understanding why they need to utilize the contract pharmacy versus all the pharmacies in the community. And they came in and we toured the pharmacy and we showed them this is what makes us different. When you call in, you talk to one of these 3 people. When you're sending information, one of the people in this section is actually going to do the data entry. Before the prescription goes out to your patient, it's been scanned by a barcode, touched by humans 4 separate times to confirm it's the correct prescription. We get done with that conversation and all of a sudden they've converted 85% of their facility over to the pharmacy because they understand what we do that makes us different. And so when you do that same thing for your local physicians, you see growth that doesn't, it legitimately does not make sense. Because what doctors think of when they think of pharmacy is a pharmacy is a pharmacy is a pharmacy is a pharmacy. I think everybody in this room knows that that's not factual. Everything we're doing, if you're doing HRT, if you're doing custom compounding, if you're doing compliance packaging for patients, those are all things that if you go to Walgreens and you ask them for any of those services, they're like, oh, we can't do that. So they literally don't have the capacity, the capability. And so like Jeff, in your pharmacy especially, you've got a great opportunity because you are a closed door pharmacy. And so how do you come in and see what that difference is? Even combo shop pharmacies. Most doctors, no idea what that even means, right? But then you plug in something like a MedSense, which you think, okay, it's a doctor. They're probably a little prickly if I'm having a doctor-patient relationship established, but we don't supersede the primary care relationship. It just establishes a relationship with the patient, and then you can continue to actually monitor that patient in a meaningful way.
And use that MPI number bill.
Correct. And use the MPI number bill. That's correct.
Which I know that's not hard to do. It's just tedious.
Yeah, I can't use it right now because I use the spill type packaging. It's the easiest way to explain it. I use blister cards, so they don't quite have it developed. But he says they're going to.
Yes, Q3.
Yeah, Q3 this year, blister cards will be available through MedSense.
The interesting thing about this is what we found is there's, right over the Venn diagram is 2 circles that overlap. Okay, so the Venn diagram of long-term care home patients and patients who qualify for MedSense, it's not quite a circle, but it's pretty daggone close. It's a pretty solid overlay, especially now that they can do remote patient monitoring. And so as you're onboarding new patients into your pharmacy, and again, you're going out and recruiting patients from local doctors, you're providing physician outreach program. Here's the doc, here's the program, here's the patient, here's their name, here's their MAR, here's a 5-star questionnaire that I've asked them 15 questions when I did my first onboarding with them. You provide that to a doctor a couple times, and they're going to pause and ask you, hey, what are you doing? How did you get this information? And that's when we have the opportunity that Justin's talking about, to invite you to come into your pharmacy and see what makes you guys different. All right, so we've talked about growth, we've talked about automation, we talked about, I think we do need to circle back to your delivery point, because you said 30 miles, 30 square miles.
Yeah, we do. Yeah. So how do you do? So how do you make that make sense on a monthly basis?
Well, we do attempt to synchronize people towards other people if they're very far out. So like we go to Geneseo, there's somebody in this room that actually knows what I'm talking about. He's from Rochester, but we go to Geneseo, that's 35 minutes west of us. So we'll take 1 or 2 other patients when we get new patients. We just get them synchronized. If we get a short fill, only fill them for 20 or 21 days first time. So they show up in the week where we're going to Geneseo. Now, don't get me wrong, we still end up going to Geneseo again the following week, but we're used to it about once a week because insulins and things like that don't match up, inhalers. And we do, acute meds too. It really depends how far out they are. We just picked up patients in Ornell. I don't go there yet. That's a long ways. That's 45 minutes. But a pharmacy closed and they were doing packs. Right? So they got a hold of us. So I FedEx those patients. People that are very far away, we FedEx. FedEx been very good for us. UPS was not. So,
So I think that's it. So basically what Jeff's saying, just to kind of recap, Justin, do you do the same thing with patients, like kind of regionalize them for delivery?
How many, do you have numerous delivery drivers?
I have one driver on every day and an extra half a route on Wednesday. We get all that done, believe it or not.
Wow.
Now, every blue moon I will do a delivery, don't get me wrong. Problems come up, okay? Problems do come up.
Yeah, we have an in-house delivery driver, just one driver, but the requirements for the delivery service are you have to be in a synchronization program to where we will go out there once a month or once every 3 months. If you do want something outside of that and you can't come to the pharmacy, then we do offer a small charge. And we did not used to do that. We used to just fill a prescription every day, deliver it every day, numerous times a day, and it made absolutely no sense.
Yeah.
Most patients are completely receptive to that. They understand they want their meds all at one time. But we do make the exceptions if it's an antibiotic or something. Obviously, we understand that's not their fault.
Yeah.
So anything like that, then we do make the exception. But getting away from a free delivery model,
Take free.
I can't drive 45 minutes out of the way for one prescription that we made 10 cents on.
Right. Scott, what were you going to say?
Oh, I was just gonna say in our closing minutes, maybe give folks some tips and tricks on where to start.
Yeah.
We talk to pharmacies and, I talk to hundreds of pharmacies a week. And, everybody's at different stages, a little bit of this or doing a little bit of that. Hey, we're gonna try this on our own. Hey, we hired a clinical pharmacist to do this, et cetera. But maybe give some advice on where do we start?
Absolutely. So from our perspective, I think the first thing to do is take a look at your pharmacy. If you're doing any one of those 3 tasks, you probably already have some long-term care at home patients. It's a great opportunity to say, hey, could we maybe take a look at this, run some data. We have some great tools and algorithms where we actually run data and tell you, here's your opportunity, here's what it looks like. The process with GeriMed, as Tanner said, does take about 60 days to get rostered with GeriMed from the time you start the NPI and CPDP process to get rostered and set up. That immediately gives you access to Optum, which allows you to start billing for that increased reimbursement. Once you're rostered, you go to ESI. That's going to take entirely too long. I think the fastest we've had it done so far is 72 hours, but that was a fluke because of an issue that ESI had. The average there is between 60 and 120 days. If you're in a heat zone, so who here's from Florida? Congratulations, you're in a heat zone for every single PBM. So Florida, basically the entire state's one giant heat zone. So if you're in a heat zone, oddly enough, you actually get faster service from ESI, but you have to pay more. And so it's a little bit more expensive. But that whole process, start to finish, is probably 120, 180 days at the most. So the best time to start doing this was 6 months ago. The second best time to start doing this is Monday, or this afternoon for that matter. Get moving down that pathway. If you're packaging already, selecting something that works for your team, something that you can do relatively easily in your pharmacy, start synchronizing your patients, getting them put together. Jeff has a great concept there of doing regionalized delivery. If you can get patients routed into a specific area, you can expand your delivery model dramatically. When we first started working with our local pharmacy, their delivery radius was inside the city limits. Now they can go anywhere in the county that we live in. The county is an hour north to south and 45 minutes east to west. Because if you're in the northern part of the county, they deliver to you on Tuesday, if that works. If you're in the south part of the county, it's on Thursday. And so that process works dramatically well. And so now they're able to actually cover 60,000 patients versus 10,000 patients. Really expand the pharmacy. So starting point is do evaluation, see if you've got enough beds. If you do, enough patients. If you do, that number's about 25. It's really a very low bar. And we start the process.
We'll do it the same way. We'll scrub your patients to see if they're eligible for the program. You make no commitment until we determine if it's a good opportunity.
And that's actually an interesting point too, because that is a much faster process. You don't have to go to a new NPI, you don't have to go to a CPDP. You can go ahead and start having those patients be worked on with Medsense, and then we can convert them over to the LTC Home side once we're done.
with that, I think, do we have any questions from the audience? Anybody have anything that they wanted to have one of our experts answer? Yes, ma'am.
So when we analyze our potential patients for long-term care at home, we always end up at question number 4. Can they, basically, are they mobile outside their house?
Yep.
And that always gets us.
All right, so-
Everyone else is yes, and
Yeah.
they can go to the grocery store on their own, so.
Let me address that real quickly. The question was, they get to the fourth portion of the attestation document. So, the way this works is you have, waiver, and then you have to have 2 activities of daily living, 3 chronic conditions, multiple medications for those chronic conditions. And the last question is, can the patient easily leave their residence independently safely? All right, so the best way I can describe this is you will know it when you see it, and a lot of times patients can leave their home safely. But let's say we have a patient who's got an LAI, they've got 3 activities of daily living that need support with multiple medications, and they're also on multiple chronic medications, multiple chronic conditions. But they have an LAI. Almost always, when a patient has an LAI, they fall under a home and community-based waiver program. So even if they're mobile, if they're a waiver patient, they automatically qualify for LTC-at-Home. So when you do the waivers, you HCBS waiver, the end-stage renal disease waiver, the Social Security disability and income waiver, does not require the patient to have limited mobility. Those are automatic qualifiers outside of that qualification by practice. One of my team members' moms, 2 activities of daily living support, actually 5 chronic conditions, 17 medications, but she can drive. Her dad can't. So her dad is a long-term care home patient. Her mom is just a retail patient. Again, 17 medications, many of which actually do make money. So it makes sense to deliver both of those at the same time.
We're gonna get cut off here. Come and see us at the RxSafe booth right on the other side of this wall.
Time for a Yeti cooler, come over.
Real quick, any other questions that we've got that are kind of broad? All right, seeing none, as Scott said, do please come see us at the RxSafe booth. We'll be available for questions there on a one-off basis. Look forward to seeing everybody there in a second.
Thank you, gentlemen. Let's give them a big round of applause.